So the error reduction principles that go along with doing a root cause analysis claims that errors can be prevented if it is assured that they can be. So if we believe that we can actually prevent an error from occurring, even if it's not something we have power and control over, we can do something that may try to lead to preventing that error in the future. So prevention will occur when prior experiences are analyzed for the intention of learning from them, when there's privacy and confidentiality that's really assured to the people who are going to talk to us. Because if we don't have that, they're not going to talk. They're going to fear being blamed. And from discussing clinical practice with our colleagues. So the more we can talk to our colleagues, the more sometimes we get into conferences and we think that they're really a waste of time. And trust me, sometimes they really are a waste of time. But the more we can communicate with one another, the more likely we're going to be able to make the changes to prevent the preventable errors. So it's important for us, each of us as an individual, to take responsibility to establish a culture of patient safety when we do our work. Now, there are a number of ways that are specific for behavioral health professionals, particularly psychologists and social workers and other psychotherapists for whom this webinar is intended. I'm going to turn over to Dr. Shapiro, who's going to begin that discussion in the area of diagnosis, and I'll come back to talk to you about some other areas later.
Thank you, Dr. Walker. Actually, before I start talking about diagnosis, I was thinking of one of the medical errors. You're talking about system errors. We read not too long ago about a directive that came down, don't know exactly where it came from, saying that post-traumatic stress disorder was being diagnosed too often at a particular hospital, and that professionals should be cautioned not to be diagnosing it that often. Now, because it costs too much to treat them. So if some patient at that hospital were to die because of, or get seriously ill because of untreated post-traumatic stress disorder, that could really be seen as a function of that system error of the idea that you're not supposed to diagnose it too often because it costs too much.
Well, that's very, very true, Dr. Shapiro. In fact, with that particular hospital, we also heard that one of the patients who had been treated there had actually been the soldier who had committed multiple shootings in one of the communities, I believe it was in Afghanistan.
That's right.
We don't know whether there's any connection or not, but there's where root cause analysis would be a good idea so that we could find that out.
Yes, indeed. Okay, well, along with the root cause analysis, there are diagnostic errors that I'd like to talk a little bit about. And these errors in diagnosis can occur both because of common cognitive errors in diagnosis and because of system-related factors. In other words, the two of them may very well interact, and very often the diagnostic errors are part and parcel of the system errors themselves. So let me talk about a few of the most common. The first is what we call aggregate bias. Aggregate bias may occur when aggregate data that's used to develop clinical guidelines do not, in fact, apply to individual patients. This often occurs when using a standard psychological test interpreted alone without other data. We know, most clinicians know, that you're not supposed to interpret a psychological test in isolation from the rest of the data. But in a system sometimes that demands rapid turnaround, rapid diagnosis, people do tend to use these aggregate assessment instruments without really thinking just about what the individual factors are. This aggregate data is used extensively in what we call actuarial assessment devices, where you're measuring characteristics of groups of individuals. And a lot of people make the error, the cognitive error that we call aggregate error, by taking a particular individual and then saying that those diagnostic statements apply to that individual without taking into account the individual factors. A second diagnostic error is what we call anchoring. This is the tendency to focus on features in the patient's initial presentation that are most compelling without considering other less obvious factors. In other words, they present with a certain symptom or class of symptoms, say hallucinations, delusions, and the clinician basically stops questioning at that point. They do not look for other more subtle kinds of features that either may be contributing to or may be causing the more obvious kind of factor. We then have ascertainment bias, which occurs when prior expectations shape the thinking. This is primarily with gender and stereotyping kinds of issues. Confirmatory bias is another one. Confirmatory bias is the tendency to look for evidence that confirms a particular diagnosis, a diagnosis that perhaps you have already made, and you basically ignore data that tends to be contrary or tends to refute the original diagnosis. Diagnostic momentum is really another aspect of the same phenomenon that we've called confirmatory bias. Once a diagnosis is given, it's difficult to change to another. We also have what is called a feedback sanction. When feedback occurs too late, it may just be a rubber stamp to colleagues, once again, with a particular diagnosis in place and no consideration or little consideration to others. There is sometimes what we call a framing effect. Here, the healthcare professionals frame the risk of outcomes for different diagnoses in terms of their likes and dislikes for particular individuals. They will give an individual that they tend to like or that they feel they can work with. They'll give them a diagnosis of some condition that's fairly easy to work with, or if not easy, at least capable of being worked with. Where for some, say, they will diagnose somebody with some sort of anxiety or depression. People that they don't like get the diagnosis of borderline personality disorder. That's an example of what we call the framing effect. Now, there are some also more other cognitive areas of diagnosis that sort of interact with these, and they're more at a, you might say, a macro level. One is the overconfidence bias. Most people tend to believe that they know more than they actually do. This has been demonstrated repeatedly over the course of many studies. An outcome bias, tendency to opt for diagnostic decisions that could lead to good outcomes. Again, another example of the framing effect. Premature closure, again, closing decisions, the decision-making process before it's been fully verified or completed. Some people also refer to what we call an unpacking principle, not eliciting all the relevant data in determining a differential diagnosis, and what has been called a psych-out error. Medical illnesses may be overlooked or not diagnosed properly. You take the most obvious psychological explanation and don't even bother to look for possible underlying medical causes. How can we prevent diagnostic errors? Well, first you have to understand these common errors and how they occur, what causes them to occur. We have to adhere to appropriate standards of care. If there is a particular diagnostic protocol, it should be followed. The diagnostic protocols will not allow for these different errors to take place. That is, if they are properly adhered to. You should perform a differential diagnosis and have rule-out diagnoses, and then utilize validated techniques for the comprehensive assessment. So all of these are ways of preventing this premature closure. You want to avoid innovative techniques unless there is no other option. You need to include trauma assessment in just about everything that you do these days. We've found that whether or not a person actually qualifies for a diagnosis of post-traumatic stress disorder, the impact of trauma is seen in a whole variety of different diagnostic conditions. So that has to be a routine part of our diagnostic assessment. Obviously following the Code of Ethics, which talks about the need to base your opinions on sufficient data, again, not to reach premature conclusions, and basing your diagnoses on multiple data sources. Then this appears in a variety of different guidelines, as well as the ethics code itself. You cannot and should not diagnose based on just one source of information. A word about negligent diagnosis. It is not merely misdiagnosis. Anybody can misdiagnose a patient. Negligent diagnosis occurs when we have failed to utilize the standard comprehensive assessments that are available to us. You have to demonstrate adherence to a standard of care, use well-validated techniques in the comprehensive assessment, avoid innovative use of tests unless it's absolutely necessary. You do not want to go off and make wild interpretations of certain tests that cannot be verified by the data. And you need, again, to be sensitive to physical illness, which may present as psychological problems. Okay, I'm going to turn this back to Dr. Walker to talk about certain high-risk clients.
Thank you, Dr. Shapiro. There are some high-risk clients that many of us do get to see in treatment. I'm going to name a few of them, but you may know of others. For example, individuals who have a psychiatric disorder or comorbid illnesses. These are people who have multiple problems, and so working with them may be problematic for us as well, especially if we can't get collaboration with their other doctors. Working with children could be high risk. First of all, we don't have or don't see children that frequently when we work with them in outpatient care. If they're in a residential care, then they're missing their own families. Sometimes these children don't have secure families that would be supportive. And so we're taking on a lot of responsibility working with these young children. Nonetheless, we need to be working with them, because if we can prevent or fix some of the problems that they have at their young, tender ages, we may be preventing a long history of psychological problems as they grow up. But we need training in working with children, especially training in the developmental stages of childhood and adolescence, and training in trauma, because so many of the children that get referred to us are children exposed to abuse in their families or other kinds of traumatic experiences. Elderly people are another high-risk population. They're high risk for other reasons as well, including the fact that as they get older, especially the older elderly, which are considered people who are 80 years old or older, may indeed have medication responses that are unique to them because of the changes in metabolism as they age. So even though psychologists and other mental health professionals are not necessarily doing the prescribing of medication, if our patients are on medication, we have to pay attention to the kinds of results that they're getting and be aware that we may have to intervene with their other physicians. The homeless is another interesting population. Now, most of us don't get to work with the homeless unless they come into clinics or we go into the homeless shelter. But getting homeless folks to really be able to follow our directives, to be able to take medication if they need it, to be able to have proper nutrition, to be able to have a place to sleep at night that's safe, to be able to be safe in other ways is often a challenge. Nonetheless, the rewards that we get for working with these people who really don't have consistent people in their lives who know them and care about them can be extraordinary.